macroglobulinemia. Does ibrutinib change everything? Yes, indeed.
Thank you for the invitation. It's a great pleasure to be here. And my task for today is in the next 15 minutes to point out some of the new things about the biology and the treatment of this rare but very interesting disease. And I will try in the end to answer this question. This is the guy that discovered this, described for the first time the disease. And it's very interesting because he's a very young from Sweden doctor. And besides describing macroglobulinemia, the Waldenström macroglobulinemia, he described also some parts of porphyria and other disease. He was a very observer doctor, just with the hands, the stethoscope, and some few laboratory apparatus. This is a complex disease, and the clinical manifestation is very heterogeneous. Some used to say that you cannot see even two patients with this disease with the same presentation. The main issue of the clinical manifestation are due to the bone marrow infiltration with the cytopenias, mainly anemia, that it's the major clinical manifestation. And this anemia can be also not just because the bone marrow infiltration, but also the disease interfere in the iron metabolism, and sometimes you need to correct this iron through intravenous reposition. The second cause of clinical manifestation is the gammopathy, the IgM gammopathy, that can, for sure, as you know, give the hyperviscosity syndrome, and the IgM can also cause other adverse clinical manifestation, as neuropathy, that you can take in mind that the neuropathy could be for amyloidosis also, cryoglobulinemia, and cold agglutinemia. In the beginning, in the first part of the disease, in the presentation of the disease, it's not common. You have organomegaly, lymphonodomegaly, and splenomegaly, and even extranodal manifestation. But when the disease relapses, this is more common. Just to point out two recent discovery in the pathobiology of this disease. Recently, the timeline of these discoveries is so short, belongs to the 2011, that the first time was presented in the ASH meeting by Dr. Trion, and as far as I know, it was chosen the best poster, the best paper at that ASH meeting was the discovery of the MID88 mutation. The other mutation that is responsible for the developing of the disease is the mutation of CXCR4. Recently, Trion in New England Journal of Medicine described 3 other mutations for the gene MID88. These mutations can trigger the pathway that in the bottom of the line can give the growth and the survival advantage for these cells. And these are what we have, the new concept to treat this disease is to use drugs that can interfere in these lines that favor the development and the growth of the cells. As in other B cells, chronic B cells disease, you don't need to treat these patients frontline if the disease is not active. And this also happened with macroglobulinemia, Waldenström disease. The series show that in the last 2 decades, we have an improvement in the overall survival of this disease. And the problem, this is related to the introduction of rituximab. And rituximab is the backbone of the treatment of Waldenström disease, using alone in 4 injections or 8 infusions, or associated with a lot of different drugs. For instance, IMIDs, similar to multiple myeloma, and you know that one of the side effects of use of rituximab in this disease is the FAIR phenomenon that I will allude a little bit after. And the use of a combination with cyclophosphamide, mainly with vincristine in CHOP-R or CVP-R, but this is a problem because these patients can have neuropathy, became worse when you use vincristine together. The use of nucleoside analogs is also used for treatment of this disease. And here we have 2 problems. The first is the immunosuppression that you know very well. And the second, it appears that the use of nucleoside analogs induces of a secondary neoplasia, mainly aggressive B-cell lymphomas. The other way to treat these patients is similar to myeloma, to use proteasome inhibitors. Bortezomib is the main drug used in this sense, but also you can have more neuropathy when you use the first proteasome inhibitor. So investigators are trying to use the second generation as carfilzomib. When you use these drugs together, rituximab, you can reach a very high overall response rate, and also a very good partial response. That means more than 19% of reduction of the IgM. And even you have a certain number of patients that can have a complete remission, that it's not common with other kind of treatments. And surprisingly, presented by Dr. Rummel recently, the use of bendamustine. And you can see in this paper when Matthias Rummel compare CHOP-R with bendamustine R in different kinds of indolent lymphoma, and you can see that the best result in progression-free survival is in Waldenström macroglobulinemia, giving very different curves in the progression-free survival. The other point is related to the maintenance, and Dr. Trion also studied this. And you can see in this publication in British Journal of Hematology that the maintenance with rituximab can also give a better overall survival. But the problem is that the patients, different as in follicular lymphoma, for instance, these patients have since the beginning a lower quantity of IgG and IgA. So the side effect using rituximab is much more pronounced in these patients than in other B-cell lymphoma. Frequently these patients have a very low IgG, less than 300, and several recurrence in sinobronchial infections can result. What is new is the trial beginning 2013, if I'm not wrong, with 3 different centers, Dana-Farber, Stanford, and Memorial in New York, using ibrutinib. And the results are very impressive. And we have an overall response rate of 91% and a major response rate more than PR in 73% of these patients. And you can see here a very good partial response in 16% of the patients. These are the curves, the PFS and the overall survival are very good curves of 63 patients. And the side effects are not different than we can see in chronic lymphocytic leukemia. Most of them grade 2, neutropenia, anemia, thrombocytopenia, arrhythmia, as you know, mainly atrial fibrillation or even flutter, and so on. This gives that the agency in the US and Europe approved very quick this drug for, this was the first drug approved for Waldenström disease. It was approved by the FDA in January 2015, and it was approved by EMA in July 2015. In FDA, it was approved in first and second line. In the EMA, it's approved in second line, or if the patient has some restriction to use rituximab or some important adverse event with rituximab. It's interesting also, we are starting to learn to niche these patients, which patients respond the most of ibrutinib, and these mutations that I alluded before are involved in the response, and the gene MID88 in the mutation status have a better response. For instance, you can see in this line patients with wild type in these 2 main mutations have no major response. Another point, it's so interesting that this is a disease, one of the diseases that most express BCL2. So it's rational to use anti-BCL2 in these patients. This is just a preliminary data in few patients, in 3 patients with Waldenström, and 100% of these patients had the response completely or partial. This is a trial that is not yet recruiting patients, use venetoclax for these patients in patients previous treated. The other drug is idelalisib, a selective oral inhibitor of PI3K delta, and we see here also published in New England last year in 7 patients, of Waldenström. In 10 patients of Waldenström, 7 have a complete response. Another study ongoing, recruiting patients, is to use idela twice a day in these patients relapsed or refractory. Just to finalize, the new version of NCCN showed ibrutinib as an option for primary and also for relapsed patients. So in summary, it's important to emphasize that this is a very heterogeneous disease, and most of these patients don't have indications to start the treatment at the diagnosis. You have a criteria for that. We have several different options for symptomatic patients, include rituximab. That problem is the backbone for combination with alkylators, nucleoside analysis, proteasome inhibitors, or ibrutinib. Rituximab induces IgM flare, and this is very important to call the attention of the doctors, because if these patients have beginning of symptoms of hyperviscosity, or if they have a higher level of IgM, like 4,000 milligrams per deciliter, you have to pay attention, because part of these patients increases this IgM in 25%, can trigger hyperviscosity syndrome. And in the end, ibrutinib response are impacted by these 2 mutations that I said to you. Well, so answer this question, I will be, as we say in Brazil, over the wall. Yes, does ibrutinib change everything? Well, I don't know everything. It changes, but we have to wait a little bit more. We have it's a new, the combinations are coming. This study have a short follow-up. So, but I think it's very interesting data that we have with ibrutinib in this disease. Thank you.
Thank you, Carlos.
Yeah, I got a
Any
question.
question?
You mentioned, you know, that especially with the rituximab-based therapies, you really can get a pretty significant hypogammaglobulinemia with IgA and IgG. Have people studied what happens with the IgA and IgG when patients respond with ibrutinib, or does anybody know that? We haven't looked?
No, I mean, you know, the data is so little
Yeah.
from that trial. You know, there's not a single patient in that trial that was previously untreated.
So
Right?
they're
Not a
all,
single patient, and yet the FDA gave approval for initial treatment
Yeah.
because of that. So, I think the main issue there is, this rituximab maintenance, which I think is totally unnecessary for this disease. You want to make somebody, an immunological cripple, go ahead and do that so you get a cosmetic response for a longer period of time. But there's no need to give maintenance for this disease, in my view.
And
Yeah, I mean, I'll tell you that, when we took 30 patients worth of data to the FDA, they said, go get another 30 and file it. So that was the feedback from the FDA, because there's nothing approved. And for those patients that, I think it's provided meaningful benefit to them. The immunoglobulins resolve pretty quickly. The hemoglobin goes up quickly. I think one of the good stories about Imbruvica is that you see this rapid resolution of some of those symptoms that the patient's having very quickly within the first 8 weeks or so. It's a few patients. It really is a few patients. And so we do have a phase 3 study that's fully enrolled with ibrutinib rituximab versus placebo rituximab, and that's your report out in the next year, and that'll help us better understand it. But we're committed to looking at other combinations as well with ABT-199 and with other things like that. We have to really try to see what else we can do. But from our original phase 1 study, there were 4 Waldenström's patients. 3 of those Waldenström's patients are still doing fantastic 4-5 years later. If you stop them, their disease comes back. So you do need to continue to treat them. So it does look like it is giving these patients highly durable responses. It's not curing anyone, but it's really putting them in a good position.
And it is what I've heard, though, is that the IgGMs drop really dramatically, which again can be some of the complications you have. And it's just interesting with that is, does that cause a compensatory, IgG? Because again, infections. So not that
No. I mean, you get a rapid IgM response, which is what you want to see. I mean, you're usually treating folks for that. But the other immunoglobulin levels.
So they stay relatively suppressed.
Yeah, and there's certainly no correlation in that setting with what the absolute IgG level is and the infection rate. The patients are way too heterogeneous and have had too much other treatments.
It just you can't tell.
But I mean, it's kind of interesting. So I'd be curious as to what the standard treatment is in Argentina or Brazil. The one regimen that I've been very impressed by, and it reflects in your slide, is the bendamustine rituximab. More than any other regimen, combo regimen, the responses and the durability of them. So, there you have a drug that a lot of people like to use, bendamustine, and you get durable responses. I think you showed a median response duration of over 5 years, versus taking a pill, which is great, it works, at $100,000 a year. 5 years later, you're $500,000 into it for a disease which really has a pretty darn indolent course for the vast majority of patients. So I think this really highlights the issue of how do we best use this drug, especially in places where there's limited resources.
So the definition of myeloma or Waldenström's is that you have the increased involved immunoglobulin produced by the monoclonal cells, so then you have a depressed uninvolved immunoglobulins. So if your IgM is high, IgG and IgA and others are low, and so if you put a chronic rituximab on it, it really can increase the infection rate. So that's one thing. The other thing is that, as you pointed out, and rituximab can cause a paradoxical rise, and therefore can cause hyperviscosity syndrome. And that's not only unique to rituximab. That is also unique. That's also could happen to chemotherapy, like bendamustine, and before bendamustine, actually, the 2-CDA is also a wonderful drug in Waldenström's. And so I really think that ibrutinib is going to change the landscape of the Waldenström's. And Waldenström's is another indolent lymphoma. It is a cousin of CLL, and with some plasma 60 features. And Waldenström's I think bendamustine, 2-CD are great, but I think that, again, we should need to develop more chemo-free therapies to replace it. Yeah, chemotherapy.
Yeah, Steve, I think you're right. I think that you've got to be selective in where you use this drug, and I think that the European Union took an opinion that in those patients who are not eligible for chemoimmunotherapy, those patients who are just unfit for it, it is a reasonable choice. I actually think that's a pretty pragmatic opinion in the US as well, and I think other places. I think where chemoimmunotherapy can give you good durable responses, I think it's a really good choice for you. I think then it's a question of in those patients where you really are starting to run out of therapies or they have other issues in terms of management. I think that's where this drug can fit. But same conversation we had yesterday with CLR, we have to find places in which you can get to a point where you can stop therapy, where maybe we can have hold the disease. I think that's the challenge for us.
So what's interesting in just listening and hearing this, it almost sounds like, though, again, is that if you had a short course of a drug like ibrutinib, you debulk especially the IgM, it's all down. Then you consolidate it with a short course of VR. That may be one that then you get a long-term remissions. That may be a way that you could do it without some of the risk of the therapies, but also gives you, and obviously always chemotherapy works if there's less disease around. It's an interesting, obviously that would have to be studied if it's better than just giving, just the VR. But, it's one of the things that, as you look, like you said, would that be a short course, and would that actually, make sense?
So before the discovery of Waldenström's, Jay Waldenström, before he discovered Waldenström's, and there's two physicians called Bing and Neil. They actually, before the Waldenström, they described another phenomena of Waldenström's that's in the CNS and in the peripheral blood. So that if you have Waldenström's in the CNS involving the CSF, the brain, and also systemic Waldenström, that's called the Bing-Neil syndrome.
Yeah.
Very rare, and I think it's going to be a perfect disease to treat it with ibrutinib that actually penetrates the CNS together with the rituximab, which also have some penetration to CNS if the BBB is interrupted.
May I? Oh, sorry.
So I just want to comment on the fact that FDA was so ready to approve this drug. I actually laud them for that, because I don't see the FDA's role as really being a gatekeeper. I think that what they need to be doing is they need to be approving drugs, making drugs available for settings where they show robust activity. I think this is a good example where this wasn't the primary reason to approve it. It was simply an indication. And Steve, I agree with you completely that to be taking an untreated Waldenström's and putting them on a $100,000 drug for years, it makes no sense. But I think, like Mark said, this will find its role. I think this may be a setting. Yesterday we talked in CLL where it wasn't clear that adding ibrutinib to chemo added anything, but I think this may be a setting where you take a regimen like BR, actually R-CHOP works well. We heard that proteasomes and R work well, and adding this drug to those, we may end up with extremely long, we're already getting long CRs, but extremely long CRs. So I actually think it's great that the drug's out there, but I think that the clinical setting needs to figure out where this drug should be used. I also wanted to point out that these MIGHTY88 negative tumors, where the response rate is much lower, they comprise around 10% of all Waldenström's. When you look at them histologically, they were categorized, or often categorized, as kind of atypical Waldenström's, kind of like the atypical hairy cell, and they probably are not Waldenström's. And I think that we need to be moving generally toward a more molecular definition, and I think it's hard to really call something a classic Waldenström's if in fact they are mighty 88 negative.
May I ask you a question for the experts? Don't you consider autologous transplant in any way in patients? Let me put a situation. You have mainly in relapsed patients with extranodal disease. The big deal is one of the situation. These patients are much more refractory. Don't you consider for specific patients
Well, I think
consolidate the response?
I mean, historically, you know, it wasn't until actually recently that we even had the combo regimens with bendamustine or with bortezomib showing better activity. So sure, you would have those occasional patients who really were refractory and maybe young as well. And so you're looking at the horizon, wondering what you can do. And I think that's what's prompted things like autologous transplant for some of these patients. Now I think, and I think there's always going to be examples like that, but with the activity of the chemotherapy regimens and now with a drug like ibrutinib, you know, you're probably going to be able to manage 95% of patients for the rest of their life one way or another. So I think it'll be a very unusual patient who fits that picture.
So I would even go further. I would say that if you look at the auto transplant literature, they don't do randomized studies. And I just have a very dim view of essentially anecdotal series. And when randomized studies have been done in other settings where people were convinced, such as breast cancer, they're absolutely negative. So I personally am not a fan of using auto in most settings, and even in relapsed large cell. The cure rate of auto is extremely low. And so, and I actually am not a fan of it in mantle cell either. So I think that until we see an absolute randomized study that proves something, I think that auto shouldn't be considered standard. And the auto people are calling their technology standard in all kinds of settings, that if those of us that didn't do randomized studies said that, people would be screaming. So, but I'm a very anti-auto person because I used to do it, and I just think it's way overused. I don't know, Steve, you?
Yeah, go ahead.
Yeah, just a curious question. What do you think the reason why IMiDs are not so popular in this disease? For example, in other monoclonal gammopathies, lenalidomide, pomalidomide, are not in macro. What do you think about it?
There's a historical trial that I started a trial with a ribamycin in mantle, and it went through fine. And Steve started a ribamycin Dana-Farber for Waldenström's. He had a dramatic bad side effects. He has 2 or 3 people went to ICU. The hemoglobin dropped, and then so that killed the study. So for rituximab revlimid combination, I think should be one of the greatest combinations for indolent lymphoma, including Waldenström's. But he either had bad luck or he had some issues with toxicity. That trial was killed. So that's why that combination is not there. But I think it was the opportunity that was missed.
And neuropathy also. And neuropathy.
Is a big issue.
Yes,
because the Waldenström's, the IgM is already attacking the neuropathy, so you have more neuropathy. Waldenström.
It's interesting. I mean, just sort of anecdotally, but some of the patients in that trial, you actually saw improvement in the neuropathy. I mean, that's never anything that I expect in treating somebody with Waldenström's. You kind of say, well, it's getting worse, but treatment hopefully will prevent it from getting any worse. So kind of stable.
So why rituximab Revlimid is a combination for metal, combination for follicular, as why is not a good combination with Waldenstrom's. One potential explanation is that if you ever take of a numerous Waldenstrom patients, that these patients often their immune system is very vulnerable, very immunogenic. You could have a allergy of medicine. There's a list, maybe a whole page of them. And I think those people, the patients with the Waldenström, so their immune system could be very hyperreactive. That maybe caused some of the hemolytic anemias, severe reactions, hypersensitivities that led to the failure of the trial. That's the only thing that I could imagine.
So we can move forward. Thank you, Carlos. Also, because the next talk is also about Waldenström disease. So I invite Graciela Molina. No? I have another program. Oh, sorry. Oh, that's then it's over. Ah, it's over. I had another program.